Okay, welcome to Mercy in Action College of Midwifery's webinar for clinical preceptors. We have put this webinar together today to talk about the challenges that we are all facing in this time of the COVID-19 pandemic. And we are going to be recording this webinar so that we realize that a lot of our preceptors wouldn't be able to come on such short notice, and they've got a lot going on. So this will become available to them. We'll be putting it up on our the special website that we have put up for COVID-19. If you have any questions, please hold them to the end. The webinar is going to be in a question and answer format. So if we haven't already answered your questions at the end, you can put them in the question and answer box. Please keep yourself muted for the duration of the webinar. We're going to try to have good sound quality, hopefully, so that we can share this with anyone else that needs it. Okay, so let's get started. This, as I said, is to answer questions, especially concerning clinical preceptorship during this time of COVID-19. And I'm going to introduce our panel today. We have Kristen Benoit with us, who is the Director of Midwifery Education and the Academic Director for our college. We have Rose Penwell, who is the Clinical Director for the college. We have Manga Penwell, who is the Adjunct Faculty and Advisor. And then this is me, Vicki Penwell. I'm the Executive Director of Mercy in Action College of Midwifery. So we'll be taking turns fielding questions today. I want to start by explaining just a little bit of this panel's deep expertise in some of the issues that suddenly U.S. midwifery is facing. And we'll be speaking to you today as both educators and clinicians, all of us with decades of experience in hands-on out-of-hospital midwifery. All of the four of us have experience in what's called easy access maternity care, which we will be describing to you later in this webinar. But in a nutshell, we have experience. We have decades of experience, each of us, in accepting late transfer of care, even up to meeting someone in labor. So we will be sharing some of that experience with you. All of us have experience collaborating across credentials, and that's a new phrase that I just made up. I don't know. I wanted to say across, sometimes it feels like it's a borderland between the different care providers that are in OB, but we all have experience collaborating, working together in practices, working with doctors, nurse midwives, licensed midwives, and strategizing emergency plans for times like this. All of us have experience training students clinically, again, decades of it, and often under diverse conditions, and attending births with students as assistants in unplanned spaces and places. And I'm thinking of Manga and students running out to a parking lot in Fairbanks, Alaska at 30 below and figuring out how to safely do that. So, I also was on an airplane one time, and a woman went into labor and had a baby at 30,000 feet over the ocean. So we do have a little bit of experience in just these sudden unplanned things, but we're going to talk a little bit about how to work when things are a little unknown, and also how to work with students during that time. And then all of us have decades of third world experience and disaster experience. Rose and I responded to a huge global disaster in 2013 and delivered hundreds of babies in tents when the hospitals were down. So we're going to talk a little bit about what will happen if our hospitals get overwhelmed. And we're mostly just wanting to share with you today some of our experience or some of our framework for being flexible and adaptable, which is what's called for right now. I also want to share our panel's deep humility today as we very, very humbly and with fear and trembling make a recording like this, because we have never seen anything like this happening before, none of us. And in fact, I was thinking about it, unless there's a really old person left alive that had memory at the time of World War I, nobody alive has seen something like this. So it's very new to us. Even the experts that study outbreaks say when something novel, when something new is unleashed, it's everyone's guess. So we're just saying that we don't know a lot of what is going on right now. Like you, we're working very hard to keep up with emerging research and best practices. That has been pretty much my full-time job, 10 or 12 hours a day for this last week. And we will share what we are learning with you as it unfolds. We have also set up a special website on our college, or a special web page on our college website. We've been updating it daily, and we'll give you that link. And we want to also invite you to email us with questions if you have them, because what affects you affects our students and affects our college, and we want to be a resource for you, because we have the time that sometimes clinicians don't always have to stay up on the latest. And I was saying it was changing daily. Now sometimes it feels like it's changing hourly. So what we are clear on, last night I saw this little sticker. This is actually one of our graduates of our college. It says, "I can't stay home, I'm a midwife," and then hashtag "I'm a frontliner." And so what we're very clear on is that midwives are members of the healthcare team. And we have not been ordered to shelter in place. That's one thing I've been a little alarmed to realize, that some midwives think they're supposed to just, stay home and do nothing at this time. We are the frontliners. We are the healthcare team. So unless we get sick or quarantined, we are out there on the front lines. And so we want to be really clear on that. We want to be really clear that midwives without a hospital experience during this time have something incredibly unique to offer the world that will likely be needed. It's already showing that it's needed. We're already seeing this increase in people calling midwives or birth centers and asking to help make a backup plan, a contingency plan. And so this is the time for creative problem solving. And as I've been telling people, thinking outside of any box we ever knew, being willing to do that. So with no further ado, we will get to question number 1. So these are some of the questions we've been fielding. These are some of the questions that have been coming to us in emails or phone calls or through our students. So I'm going to give this first question to Kristen to answer. And the question is, will Mercy in Action be pulling your students from clinical placements like we've heard some other MEEC schools are doing? So Kristen.
So yes, at this time, we are not doing that. We are not pulling our students from clinical placements. At this time, only 2 MEEC schools have pulled students from clinical placements. And these 2 schools are actually MEEC accredited programs that are part of a larger university system. And so the university was the one who made that decision for them to pull those students from clinicals. So at this time, the answer to this question for us is no. And we are constantly talking to other MEEC schools and staying in touch with what they are doing also.
Okay, thanks, Kristen. Question number 2, how do we justify having students assist when we are limiting the number of people at birth? And I'll make this just a little bit broader and stretch that out to all maternity care, that we were used to doing things in a certain way up until really recently, and now we're being asked to limit numbers. So I want to answer this question in the same way, really, that the doulas of the world have been trying to answer this question. And that is that in our mind, students unless they're at the very, very beginning and are observing, but any students in an assist or primary student role are very, very valid and vital members of the healthcare team. They are vital members of that midwifery team. And so we are saying that, yes, we're supposed to limit unnecessary people. Yes, we have to limit visitors. Yes, we might have to limit how many family members. But we're wanting to be clear, just that as doulas right now are working really, really hard to get the message out there that they're actually part of the help. They're the helpers. They're not visitors. We want to get the word out that students in a midwifery practice are considered part of that practice. They are part of the team, and as such, they play a very important role. We'll be talking a little bit as we go on how that role might be shifting, and it will have to shift. And I think that as we really work hard to preserve our licensed midwives so that they can attend all the heavier load of births, students may take some other pressure off of them. One student and one midwife may become the home birth team or the team in one room in a birth center. So we feel like our students are very, very vital at this time. And like I said, I will differentiate between this is not the time probably to take a brand new green student that's not been in any clinical and is just going to observe. That it's not the time for this, but besides that, every other student in a sister primary phase will be very important. Okay, the next question, how do we keep our clients and staff as safe as possible during this pandemic? And I'm going to give this question to Manga, who is a midwife at Alaska Family Health and Birth Center, the birth center that I founded in the 80s in Alaska. And I have been extremely impressed with how well they have made policies and are able to articulate what they're doing right now to keep their clients and staff safe. So Manga, I'm going to throw this to you first, and then if when you're done, anyone else has anything to add to that, because I know we've all been really listening and reading everything on the research. But Manga, go ahead.
Sure, thanks. Well, when we first started dealing with this, we got some advice from the local epidemiologist, and he said, everyone's going to get the sickness probably at some point because you are frontliners, and it's just a matter of keeping away from each other and staggering your presence in the birth center or in the home so that you don't expose each other. So that you don't, and also that you're not exposed to the same things. So I have not seen my sister midwives or touched them in 2 weeks, which is really sad, but that's okay. It's to keep people safe. So for in clinic, we have a group of midwives who work together. So one midwife is doing phone triage from home and is like incredibly busy. And then there's another midwife in clinic doing visits, and they're staggering the prenatal visits so that there's no overlap of any clients in the birth center. So that midwife is doing any prenatal visits, and we're doing a pared down version of visits for postpartum and prenatal. So not as many as normal. And then there's another midwife going out and doing home visits. So none of the midwives are overlapping their own presence in the birth center at all. And we're still going out 2 by 2 to the home birth, but we are trying to keep 6 feet away from each other. And we have a very long protocol policy about if they have the sniffles or who's going to wear PPE when, and that's all kind of spelled out in that letter. So that's how and that is in addition to just very basic washing your hands. We have a very severe shortage of masks, which everyone does have, and we don't have any sewn masks. So basically we're not getting near anyone who has symptoms. So we're doing telehealth as well. We're getting that set up. That's going well. It's just been a huge learning curve to figure out how to keep each other safe and keep everyone else safe. Any other thoughts, Vic?
That's great, Manga. Thank you so much for sharing that.
Mhm.
One of the things that I've been really impressed by in listening to different epidemiologists and different experts speak is that close contact is considered being less than 6 feet from someone for more than 10 or 15 minutes. And I was really thinking how we can rethink even our visits, where we do so much talking. The actual getting close and touching someone can be done in 2 to 3 minutes easily. And most of our long prenatals are talking. And so that's just one of the ways that we can think different to keep everyone safe. Also, if you do have a senior student with you, it might be wise to think about making birth teams, like I said earlier, with a midwife and a student, and so that you don't have to risk 2 midwives at the same time, because what we're trying to do, Amanda said that so well, they're saying maybe 50 to 60% of the population or more is going to get this eventually. What we're trying to do is stagger it so that we have enough midwives to meet the need as we go. I'm going to refer you to our website. To this question we could talk on for hours and hours, so I'm going to refer you to all the information we put up from reputable sources on this new website, which we're making available to you. So thank you, Manga. And if we need to circle back to this one later, we can do that. Okay, the next question is, what is easy access care and how can it help during this pandemic? So for this, I'm going to ask Rose to answer. Rose has spent years building easy access birth center in America, in Boise, Idaho, and I want her to explain and describe it to you because it's a beautiful model for the time we're in, but not a lot of people are really familiar with it. So Rose?
Yes, thank you. Well, first, I just want to acknowledge that this is not the traditional care that midwives offer in the United States. I think that it can kind of be mind-bending to picture shifting toward this. But I also want to acknowledge that this is not business as usual right now. Nothing is the way that we've known it to be. And so if this is your first time thinking about offering easy access care, which I'm going to tell you what it is, I just want to acknowledge that it might be scary. So I understand that that is a shift. But easy access care, as it's defined, is the idea that every pregnant woman that walks into your birth center or calls to try to access care, hopefully she calls first so that you can screen her on the phone, every woman seeking care is going to be seen. And the benefit of that, because you might be asking, well, what if she's not a good candidate for my care? Why would I get her hopes up? Is because women right now are scrambling and they're trying to figure out how they're going to access care in the middle of a rapidly changing healthcare landscape. And so you have access to more resources, even if she's not a good candidate for your care. So the easy access component means every woman is going to be seen regardless of her insurance, regardless of her ability to pay cash out of pocket. The idea is everyone can be seen, and from there you can triage. So you're going to be doing a rapid assessment to determine if she's a good candidate for your care. If she is not, then you can use your referral network as needed. And again, that's that component that you have access to more resources than she does. You've been working in this healthcare setting, and so you know who is taking, women with this condition, or if she needs to be with, an expert maternal fetal medicine provider. And so you can help her tap into some of those resources. In addition to the medical care that she's seeking, women that are looking at easy access care might also need additional resources in the way of food or help with shelter. So you can be an additional touch point there where we don't have women that are expecting a baby falling through the cracks because they didn't have access to the care that they needed. The other thing that you can offer for them is kindness, which can never be underestimated, the value of that, the kindness and the love and the support that they need during this really scary time. I know as healthcare providers, we're wanting to be wise, we're wanting to be informed, we're wanting to work smart, but pregnant women are very scared right now. They're anxious, they're fearful, and so interacting with you, whether it's the ability for her to actually be under your care or just that one touch point and then you helped refer her on, that interaction, being kind and supportive and loving, is a game changer. And I want to say also about my own personal experience with it. When I was 22 years old and living in Hawaii, expecting my first baby, I was accessing traditional prenatal care at the local provider as an OB. And late in my third trimester, they had us do the tour of the hospital. And as I walked through the hospital, I realized with certainty, I will not have my baby here. I'm not going to have my baby here. I just knew right away, this is not the setting for me. And so I changed providers very, very last minute. I actually flew home to Idaho and had my daughter at a birth center in Idaho. And I arrived on a Tuesday and she was born on a Wednesday. So when I say late transfer of care, I transferred the day before she was born. But being able to access that care was such a game changer when I realized the plan that I had in place was no longer a viable option for me. And I knew that I needed to shift. Having access into care made all the difference for me. So easy access care, how can it help during this pandemic? I know I've talked a whole bunch right now, but I just want to say we're short on providers. And I know that there's a growing feeling of fear among midwives, wondering if we're going to be stretched too thin, wondering if we can still provide good care for the women that were already signed up under our care, wondering if we're compromising by being exposed to more people. But I do want to encourage you that easy access care can be done smart, and it can be done as much as possible safely, especially if we're doing a lot of the triage on the phone. But having another provider in the community that can help support women that are scrambling in a last minute change and don't have access to the plan that they thought they had in place can be a game changer when we're incredibly short on providers right now.
Okay, thank you, Rose. Thank you. I also want to just mention that Mercy in Action as an organization has 29 years of background in providing easy access care in a third world country, and especially to the poorest people in that country, because their entire lives are basically a crisis and a disaster. And we are fast approaching 16,000 babies that have been born under this easy access care model. All of us that are on this panel have experience of having people come in labor and arrive in labor. And when systems are down, when hospitals are not available or they're not a safe place to go, then that is what you see. So it's unusual in this country, but it's been something we've been doing for a long time. And even when I started in Alaska back in the 80s, that was the vision and the model was that pregnancy was a ticket in the door, or it was a ticket for my attention. And we'd sort out the money later and we'd figure out that part later.
Yes.
Rose,
sorry, one other piece I wanted to share as well. Michigan has a volunteer sign up for medical providers for the state for this emergency situation. And as I was going through the process of signing up as a provider here for whatever is needed and however I can be helpful, I realize it's very much that same thing too, of it's not ideal that you first meet your patient in the middle of the event, but as a point of critical mass, being able to provide care for a woman when she's in need, even if it's not ideal that you got to build relationship with her for 9 months and work with her and get to know her whole story and all of her kids' names, it's what's going to prevent further disaster. Does that make sense?
Good. Thank you. Thank you. And if things get as bad as some people are predicting, and I hope they don't, I very much hope they don't. What we're doing right now is we're putting into place emergency complication plans. And if they do, then we're going to need guidelines on how to safely accept late transfer of care. And we have been hearing on webinars, and we've been reading some of the things happening on social media. And it seems like there are some groups of midwives that are saying, well, don't change anything. If you've got these practice guidelines, stick to them. So I want to say there's a difference between sticking to practice guidelines, as in you're not going to take a hypertensive diabetic woman. That's different than not sticking to your practice guidelines that said, I always want to see everybody before 20 weeks or before 28 weeks, or everybody has to pay me by 36 weeks. That's what we're asking people to adjust, not the actual guidelines of safety. So the next question I'm going to toss to Manga. We have been asking you to give me tips on safe guidelines. If you're saying I should be thinking differently and willing to accept late transfer of care clients for those midwives that never have, what are the safe guidelines for how to do that? And how does it not become just a lot more work in gathering records and things like that? So Manga?
First of all, we have been working pretty closely with our hospital providers in our city, and we have a very good working relationship with them already. So that was the first thing we did, is because we know that people who are transferring are coming from them. So we reached out to all of the hospital providers in our town, and we gave them, because we knew that the clients would be talking to them, we gave them a copy of our risk assessment tool, which states what we as midwives, direct entry midwives in Alaska can and cannot do, so that they will have a reference point, first of all. And our regulations in Alaska, we have to have people sign the informed consent for out-of-hospital care before labor starts. So that's specific to our state. But we will, really what we're doing is, if someone calls us and they're not in labor, we'll talk to them on the phone. I think that what we have decided within our practice is what works the best is people who are low risk in planning a natural delivery in the hospital anyway. That's kind of working the best, but really we'll talk to anyone and just see what their motivations are, which is pretty obvious right now. Talk to them on the phone. We are doing like FaceTime birth center consult visits. And really it's just time with people, which we have the ability to do that right now, and making sure that they're right for out-of-hospital care. We're setting up an initial visit with them. And we expanded our clinic hours so that we are seeing people Monday through Friday, and even on the weekends, if a midwife is free, to do that initial visit and really talk to them about birth center care. And get their informed consent for being in our care. And so that's how we are doing it. Just a lot of communication, a lot of talking with the hospital providers, women. We're getting the word out on Facebook. That we are accepting late transfers. Yeah. Anything else
great.
you want me to add to that?
And I know you told me too. Yeah, I remember you told me that you're putting the onus on the client to get their own records from their providers.
Right. They have to show up to any initial visit with records in hand. We cannot see them if they don't have records. That's a huge stipulation, actually, because we need to go through their records. That's one of the ways, not only just verbally with them, but looking concrete. What are your risks? What's been going on with you already? And this isn't the time we're going to be stretching the limits. So we do want to keep people safe. So like we're not going to push boundaries. They do truly need to be low risk. And that's been working really well. I think that part of it with their prenatal records, we are even calling their hospital provider and talking to them on the phone too, if it's a very late transfer, and just talking to their hospital provider, what's been going on, what are their risk factors, if any.
Okay, perfect. Thank you so much, Manga. That is great.
Mm-hmm.
All right, next question. What if I have to trade call at the last minute with a midwife who is not yet an approved preceptor with your college? So this has been a concern because most colleges require all kinds of paperwork, some of them weeks in advance of starting. So I'm going to toss this ball to Kristen to answer.
Yes, so this is a really great question that we have been getting. And if you're already an approved preceptor with our college, which you probably are if you're on this call, then you know that in order to sign for our students' clinical experience, you first had to apply and become approved by our clinical director and sign some paperwork, an agreement, a contract with our student. So what we are doing right now is we've created a temporary policy, basically a temporary waiver for during this crisis, that we will be lenient on this. If we have a preceptor who had a last minute need to send another midwife in her place with one of our students, then we will evaluate later if that midwife is eligible to be a qualified preceptor. And it will be up to our students to work with that midwife to submit paperwork after the fact. But we are going to do our best to work with our students and with any other midwives who end up in an experience with our students to try to get them signed up and approved and allow them to sign for our students after the fact. So our typical policy is that clinical events have to be signed in real time, working on the assumption that the preceptor is already approved. So just to give you some background for that. So again, if you are in a situation where last minute you send your student with someone else, we will be looking at that and trying to help our student to get those experiences, as long as the midwife that the student ends up with is someone who would qualify as a preceptor. And we are expecting that there will be more last minute collaborations and midwives partnering in new ways as we move forward in this crisis across the country. Certainly if you are in a solo practice, but you have other midwives that are your typical backup and you think there's a high likelihood that your student could end up at a birth with them, then communicate that with our clinical director. But otherwise, just know that we are really trying to work with students during this time to help them count experiences and just be more lenient than usual with our policies. And just we're all doing our best with what we have, right?
Good, thank you. Yes, we are wanting to support our students in every way we can because we feel like they are such a support to the midwife community, and because we don't want to hamstring any of them during this time so that their graduation and becoming full members of this workforce is hindered also. So that kind of leads to the next question. Some preceptors are really clear on how their students help them, and they know that they're vital. Other preceptors that might be new to having a student are kind of thinking, yeah, but aren't they just kind of in the way? So I want to give this to Rose. Rose has always had students and done a phenomenal job with bringing them fully into the team in every way, not leaving them on the outside at all, but bringing them fully in and utilizing them, which is a win-win for students and preceptors. So Rose, would you like to talk about ways that, especially during this time when everyone's stressed, that students could be a strength rather than a weakness?
Absolutely, absolutely. So students can be such a powerful part of the team as we're working longer hours, have late transfers, have increased workload. And some of the ways that I have utilized the workforce of students in my own practice is through a lot of the work that we do as midwives behind the scenes without even really thinking about how we could delegate it. So things that can be delegated to students would be things like stocking either a birth center or a birth bag. And I know that it's very personal exactly how things go in your bag and how it's stocked and what's in there. And so toward the end of making sure that those restockings happen in just the way that I like, I would always make a restock checklist. So at the end of an event, there's no guesswork that goes into it. You don't have to try to remember, what did we use? Oh, that's right, a catheter, 2 IVs, you know, whatever it was. You just can take everything out of that compartment and then just go through the checklist and make sure you have exactly how many gauze, exactly how many, you know, instruments. So I think stocking is a way that students really can be a help to the team, as well as taking inventory, right? So we need to make sure that we're not running out of our supplies, that we're not running low of essential equipment. And so students doing inventory is a helpful way that they can participate in reducing the workload on a midwife, as well as sterilizing instruments after a birth, sanitizing a birth room after the birth happened, working on laundry. And then another thing that I think really is beneficial, in addition to the clinical work that the students do, is considering if they might be able to triage phone calls for you, right? So of course, if it's a clinical question, then you would want to make sure that you're in on that conversation. But what if you have been on a long birth and just got home and you're only in a half sleep because you're waiting for that phone to ring, and you know it's just going to be someone rescheduling or asking a question? In my own practice, I found it very beneficial to incorporate students into sharing phone calls and time on the phone, whether it's calling to update a client on scheduling or fielding phone calls and determining which ones actually need a midwife on the line versus, you know, rescheduling an appointment or asking simple questions about if you're accepting new clients. And so utilizing students in that way can really help use wisely the
Okay,
resource
great.
of a full midwife.
All right, great. I just want to say that for most of my midwifery career in America, I was used to always going to births with myself as the licensed midwife and then one student. And so one of my priorities was always with any student to immediately get them up to speed on certain important things, like training them how to do resuscitation, for instance, in case you know you need to have them do that while you're dealing with a hemorrhage or something, having them quickly know how to draw meds, have them learn what is every emergency thing in your bag you might need and things like that. So really think differently about, instead of going in some kind of a linear fashion to train your students, which some people do, they start them on the desk and then they go to prenatal and then they finally get to come to a birth. Think about getting them up to speed as a birth assistant quickly, because what we're looking at in the future is that midwives' caseloads are going to be possibly doubling and tripling in this time. So if it's possible to use a more senior student as the, or even an assist student as the main assistant. I have found that worked very, very well, and actually did it for years and years when I was in Alaska. Okay.
Absolutely.
Let's
I'll add
go
one other piece as well, which
yes.
is that the benefit of having students help with restocking and inventory is that they know exactly where everything is. So then when you run through some of those drills, there's not a question of which compartment or which drawer, but students are really ready with immediate response because they just have committed to memory where every single item belongs.
Perfect. Okay. And again, if you're used to using students are doing things in a certain way, we're just trying to get everyone to think outside the box. All right, the next question: how will I know my student, or myself for that matter, can make it to a birth if our area is on lockdown? I have gotten a lot of this question, and I think part of this stems from confusion about who's on lockdown. And I want to just really, really reiterate that medical professionals are not on lockdown, and every single policy that's being made right now, whether it's an actual like law or, you know, it's like whether it's just you know, they're saying, okay, San Francisco shutting down, New York is shutting down, the whole country of the Philippines is like under martial law right now. You don't go anywhere without armed people with guns and checkpoints. But we're trying to be really clear with our medical staff that you have an exemption from that. So we were a little late to this, realizing this, but this week we actually created a letter and a special badge for our students. And it suddenly came rushing back to me when people started saying, what am I going to do? Because they just locked down my city. They're saying we're not supposed to go out. And I remembered that in the disaster zone that Rose and I responded to, a badge around your neck saying you were a medical person got you in everywhere, got you through anything, got you into places where nobody else was allowed to go. So we started making this for our students. We have told our students that we will make a badge with the name of the practice they work in. This is an example here, and then a letter that we have given all of our students, whether or not they're in clinical right now in case they get pressed into service, that they could show if there's a curfew, for instance, on the street and nobody's allowed to pass, but they could show a letter, they'd have a badge. I want to make this a little bit broader because my husband is our IT and our typesetter, and he has offered if any of our preceptors don't have a badge. If you have no identifying thing on you really with a picture ID, most of our state licenses and CPMs cards don't have a picture. So if you would like a badge like this, which would be just like what you're seeing here, only it would just say midwife at the bottom and it wouldn't say our college. Last night he cranked out, I think, 6 or 7 of those for our clinic in Alaska. So he'll make them for you. So let us know. So that's all I want to say about that. We are prepared to help you in any way we can. Now you could write yourself a letter if you have letterhead with your business logo on it. Write yourself a letter, create something like this, but we're offering to help if you need us, because that's the big issue. And it kind of snuck up on me. I'm not used to those kind of lockdowns in America, so we're all having to think different. Okay, we're going to spend a few minutes here talking about disaster response and birth refugees. And this really has 2 parts to it. So I'm going to take the disaster response part, and then I'm going to ask for some of the others on the panel to talk about the concept of birth refugees. What I want to talk about in a disaster response is that this is no time. Rose said it really well, and she said no time for business as usual. It's also not a time for any kind of profiteering. It's not a time for any kind of what's in it for me. I know midwives have fought so hard for so long to have respectability and credibility and to get paid for what we do. But let me give you a little analogy. Let's say your life work was that you were a builder and you had an earth digger machine. And this is what you did, and people paid you a lot of money for your expertise. But let's say that your community had an earthquake and a building has fallen on a lot of people, or there was a bombing, like a 9/11 type situation. You would respond, and you would bring your equipment, and you would bring your knowledge and your know-how and your skills, and you would bring that earth digger there to try to save people in this crisis. But you wouldn't ask people to pay you in advance. You might not ask people to pay you at all. You would have a whole nother understanding of now this job suddenly has become life-saving. It's not just routine that you do your work and get paid for it. Now you have a chance to really make a difference and help people. And I think I'm not sure it would get to that point, but if our hospitals get overwhelmed like they have in Italy, it's possible that we are going to need to really realize that in a disaster response, you don't ask people to pay you. You don't reach into rubble and say, yeah, sure, I'll grab your hand and pull you out, but you know, that's going to be full charge. So I say that carefully because I don't want to offend anyone. I know that we all have to live and we're all going to be working harder, but there's a certain point where our human altruism has to kick in, and we might be donating what we know how to do so well. And I definitely can see that coming. So with that said, and we should all be ready for that. And again, it's part of easy access care that we just, it's not the most important thing to us to worry about that piece of it, but somehow we've been able to do this for decades, and it's all worked out that we're all still here functioning. So I wanted to ask Kristen to speak a little bit on just that term birth refugee, because she worked in a practice where the midwife she worked with used this term. And I put a few little definitions here, which Kristen, you could read, or just tell us your concept as your midwife partner would talk about it.
Yeah, so let's just look at the definition of a refugee on the slide. A displaced person, a person forced to escape war or a natural disaster. So I, like Vicki said, I worked assisting a midwife for quite some time, who she was the first person I ever heard use this term, birth refugees, because she actually really loves taking women who are late transfers. She would say, if your baby's not actually coming out, then it's not too late to transfer. And she really just felt like she could offer the home birth model to people who, if that's not what they were originally seeking, but something changed to make them seek that model at the last minute. She really had a high value on being a safe place where, if they were appropriate transfers for out of hospital, that she really wanted to help them. And from the financial standpoint, she always really, I thought, had a really great way of looking at it, because she looked at everything in the whole picture. And she said, in the whole picture of my practice, some people are going to be able to pay me full price. Some people are on a sliding scale. If some people come in at the last minute and can't pay much, then it all evens out in the end. And that was kind of her philosophy for helping people last minute when it comes to finances, is that it all evens out in the end. I can't say no just on the basis of money. And of course, that value, as you've heard, resonates with Mercy in Action and with our concept of easy access care. And particularly in this time of just, it's not a natural disaster, but virus spreading across the country, it has the elements of a natural disaster. It's really a time when women are looking for other options. And I think, like Rose was talking before about, even if women aren't able to directly transfer into our care, if they are higher risk, to be that point of contact where people can come in and just receive that spirit of welcoming and kindness when they're so stressed, especially people who are late transfers or looking to be late transfers. I was thinking the other day how stressed I would be if I were having my babies right now during this time. And I think that's the most important part of helping these birth refugees, whether or not we can be their providers, is just to offer them a place of just kindness in this crazy time. So I don't know if Rose or Manga have anything else to add to this topic also.
I would just want to say, and I feel like I speak for all of us or most of us, is that every time I have an interaction with any mom, just having so much compassion and kindness, checking in with them, because we're midwives and we deal with the whole person. I want to know how they're doing emotionally, just checking in. Just every person, adding kindness to the interaction is just hugely important.
Yes, and never more than in a crisis or a disaster. I want to tell you about a little study that, well, it wasn't a study so much, it was actually a chapter in the book, Birth Models That Work. There was a practice of midwives in England, and in England, the same midwives work in all settings. So they have hospital privileges and they also work at home. And a certain group of midwives put up a center, and they decided to try a little experiment that they told women, whatever you are planning for your birth, and you know, people make birth plans. They said, when you go into labor, we'll come to your home and check you first. So if you're planning a hospital birth, we'll just come to the home and we'll check you at home, and we'll, you know, see how labor's progressing, and then we'll go to the hospital with you. And what they did was, when they went to these early labors just to monitor at home and then go to the hospital, they brought all their equipment. And then when they got there, they told the women, everything's normal, this looks great, let us know if you want to stay here, or do you want to go ahead with your plan to go to the hospital. And I can't remember the exact number, but I think it was almost half of the women in those circumstances said, can I just stay here? So that was so fascinating to me, because we think in our culture here in America that it's not normal for someone to make a different plan at the very end. But actually, and I've heard this said before by people, that there's a lot of women that when they actually get really close to having a baby, they start nesting, they really wish they could just stay home. But our culture is so strong in America that we're so programmed, you're supposed to go to the hospital. So I just wanted to say that to let you know that we're in unusual times now, and women are reevaluating things that our culture has never really encouraged them to reevaluate before. But it's not abnormal for women to suddenly want to change their plan. And I say want because we're still in the place where it's a desire. I hope we don't get to the place where it's an absolute need, that the hospitals really truly have no beds and no room, and it is not a safe place for a woman to go. I hope we don't get there, but we might. And when we look at what's happening in other countries, we have to prepare for that. And so again, that whole concept of sheltering someone in a time of danger or trouble, we're just trying to put that out there. I know the midwives in Washington State have all gotten together, and they have been asking questions like, not like what we can get out of this, or do we want to be this busy? It's more like, what could we handle? Like what could be our caseload if it really came push to shove? Because they're seeing what's happening there. They're at the epicenter of the outbreak here. And they're saying, could we do 1,000 more births, you know, in the next few months? Could we have enough people? Could we pull that together? Or could we double or triple what we're doing right now? Like, what's conceivable? So they're really making contingency plans for if a large number of the birthing population literally become birth refugees. Okay, and Manga said it so well, compassion is so key, a willingness to help. And that's where the altruism comes in, to just say, this is a serious time and I just want to help. And if we get really to worst case scenario, then that's what we're planning for, is literal survival. We need a fresh paradigm to prepare for a disaster. It's no longer business as usual. You've been hearing that. There's people really right now that are very concerned about what's happening in New York, where they have now certain, it's not just one hospital, it's kind of a chain of hospitals, have decided that a woman can have 0 companions, and that if she tests, and they're going to test everyone, and if she tests positive, even if she's asymptomatic, they're going to take her baby away for 2 weeks. So there's people that are worried about the long-term effects of things like this. So I think we're gonna need to be ready for that. We already know hospitals are calling birth centers and saying, hey, can we write you into our plan if this gets crazy? I know Manga said in Alaska they got a call and said, like, if they had to, you know, use the space that would have been their normal delivery ward, could they have people come to the birth center? Here in Idaho, we have actually contacted the doctors at our local hospital and said, we have a birth center here. Would you like, if you need to use it, if you need to come here and use it, your staff would be welcome to this building. So, and then, like I said, midwives in Washington are really strategizing, like they're running numbers. What could we do? How could we scale up? How much is possible that we could manage if we need to? So our present system may need us. I think right now on an individual basis, Every midwife I've talked to has said that they're getting calls. So we're already seeing what's happening on an individual basis, but we haven't yet seen what would happen if our system gets overwhelmed, if our medical system was to the point of collapse. So, okay, enough said about that. Let's do this well. And we really want, within our role in this call is as a college of midwifery, and we want preceptors and all of our students, all of our faculty to work together as a team. We're going to support you. And I had fun pulling these pictures up last night. This is our future. These pictures were all taken of different cohorts of students in our school. They're students now, but they're future midwives. And we are seeing them as a vital part of our nation's maternity care team. So we want to do everything we can to keep them safe, but to keep them deployed during this time, to keep them serving you as the preceptors and the providers. You are essential as a provider. You don't have time to get sick or timed out on quarantine. And so we really want this to be a time when we can all work together and we can really see our students as that part of the whole team, and that would get into the psyche kind of our nation. Okay, before we're finished, we have just a few more minutes. One of the things we've done to try to be a little bit of help, if it's help to anyone, is we already had a class online called Midwives Responding to Disasters. And we have put it at half price. We did not write it with the specific idea of a epidemic like this or an infectious disease, so it doesn't really talk about that, but it does talk about working when systems are down, when hospitals are overwhelmed or can't take people. And it has a lot, we have been hearing a lot from midwives that if they took it in the past, it's replaying in their head now. So that's why we decided to offer it at half price. And so that is a resource that's available. And I wanted to end with this quote because in trying to get any kind of a framework or a grid for what's happening, the only thing I keep hearing referred to, or even in my own reading of history and biographies, that I can really have a touch point, is for how the entire world had to shift during times of war, like world wars. And so I like this quote by Winston Churchill when he said, "What is the use of living if it be not to strive for noble causes and to make this muddled world a better place for those who will live in it after we are gone?" I thought that was inspiring. Okay, we are here for you. We do have time to take some questions, and I would like to ask Kristen to help us with questions in the question and answer box. And before we do that, I just want to let you know that this slide has information on how you can reach us. If you have any questions, like even if it's something like, you know, does a cloth face mask work as well, or what kind of this or that, like we are just immersing ourselves in research on this issue right now. So feel free to email us. If you have any questions and concern about your students, get a hold of Rose, our clinical director, and then take down this website. It's actually really easy to find. Just go to the Mercy Inaction College of Midwifery page. It's mercycollegeofmidwifery.edu. And if you look under the college tab, the very last pull down says COVID-19. And we have been updating that daily. And there is a lot of good resources. If you scroll to the bottom, you see all the reputable sources for all kinds of things, like World Health Organization and CDC and evidence-based birth. And then as we have been adding every time a new webinar goes up or a new something is printed, new information. I just put up there last night at about midnight, I posted the documents that Manga was referring to that Alaska is using. I found very helpful. So those could be maybe a model. So Kristen, I'm going to turn it back over to you for question and answer, because if you can see those on your screen, I can't.
All right, so if anyone has questions, I haven't seen any come through in the chat box. If you are on a computer, if you just move your cursor, you should have a bar along the bottom that gives you an option to click on the chat box. If you're on a phone or mobile device, if you tap your screen, you should see a bar come up that has an option for a button that says chat. So if you do have any questions you'd like to ask, we would like for you to type them in the chat box so that we can try to get to that before we end here. I do not see any yet, but I will wait a minute and see if any come up. Okay, we do have one question. How are other midwives handling mamas who are symptomatic and in labor, serving and transporting?
I can answer that. If they have any symptoms, we cannot attend them. And if that would be for us, we would consider that an antepartum transfer, but just intrapartum. Like we cannot go and attend them if they call on the phone. But hopefully we have a heads up of who is sick and not sick, so that we can give them a heads up beforehand. That we cannot attend anyone in labor who has symptoms of COVID. So they would have to go to the hospital and be delivered there. But our people know that already. It's just, it is not worth the risk to take a midwife out for 2 weeks to help a client when we have 4 more who are due. So that's how we're handling it.
Thanks, Manga. It looks like there's another follow-up to that, Manga, if you're able to answer that. Are you following the cough, shortness of breath, temperature protocol, like as far as your signs and symptoms, I think?
Yes, we are. So those are a hard stop. If they have cough, shortness of breath, fever, that's a hard stop. They've got to go to the hospital. Where it gets a little tricky is if it's just the sniffles. Do you know what I mean? So we are deciding that if they have any kind of symptoms that are not those 3 big ones, that we're going to take it as a case-by-case basis. If it's just like the sniffles, then they're going to wear a mask during labor. The midwives are going to wear a mask during labor. And also we're going to discuss on a case-by-case basis with our clinical director if it's right for us to go. It'll be based on the midwife's comfort level, the clinical director's input, and wearing masks for everyone, even the mom in labor. So that's how we would handle that sort of gray area. Water birth
and again,
is fine.
This is too. Okay, good. Yeah,
Sorry.
Thanks for answering that.
I think you're talking about in the birth center. Yeah, we have the birth rooms that are clean and disinfected. As far as a home birth, that's a good idea.
All right, and then there's a question about social distancing.
I cannot see that.
With social distancing being so
yes.
important, should we be counseling families to have no visitors, including immediate family? This is someone from a rural area where there's not yet many cases.
I think the best advice right now that we're hearing is to not have extra family at the birth. Part of that is, again, because we need to preserve our healthcare professionals. We have to not infect them. I think that if everybody was symptom free and a family wanted to have people visit their new baby, at this point, we're not hearing restrictions on that. They are saying definitely not kids at birth and not just invite everybody you know. So this has been a really big cultural change also, that a lot of midwives have just always said, oh, it's up to you, invite anyone you want. And so that really has had to be shifted a little bit. Midwives are trying so hard to still keep with our International Childbirth Initiative, 12 steps to safe and respectful maternity care. And we will probably never deny somebody a companion, but I know midwives are limiting it to 2, and they're really saying not children, not just extra people in and out. And one of the problems, again, we have to think of exposures is it's not just 2 at a time. It has to really be that they choose, or whatever number you set, that they choose who that is, and that there's not just a lot of people coming in and out. But I think that's mostly for the birth to happen. I haven't really heard that anyone is saying that nobody should come and visit a new baby or anything like that, if that's what you were asking.
Can I say something?
Yes.
What we have started doing for the midwives is, and it helps get everyone in the right headspace, is when we are going out to do a home visit or home visitor come to their house, we are getting their permission for us to be in their space. And we are taking our own temperatures before we go visit people. And so that's helped us get their frame of mind right too, of like, are we, I myself as a midwife am symptom free. I don't have a fever, cough, or shortness of breath. Is it okay for me to come and do a home visit at your house? And so that has been helpful to get everyone's frame of mind right. Like, are we all safe to do this? That also helps them put in the right frame of mind so that they are not having other people around when we come over. And it will be really helpful to just get all of that informed consent and everyone realize the huge importance of it.
Excellent. I wanted to say one more thing, that one of my sons is a doctor, and he was telling me that one of the best practices we should put in place, which I hadn't even thought of, and this might be hard to do in Alaska right now, but for most of us, what he was saying really would be best is if we have birth centers and people are coming in to our space, to meet them outside the door and take the temperature there, and just make sure that if somebody is febrile, they don't walk in and be inside. So again, that might shift a little bit, because usually we're used to just bringing people straight back to the birth room, but maybe just do a really brief screening at the door. And yeah.
That's what we're doing in Fairbanks is, yes, no, the door is closed. Like, you have to be screened before you come in.
Okay, good.
Okay.
All right, I see a question I'm going to give to Manga or Rose about doing visits over the web somehow. Or Manga, you were talking about doing FaceTime.
I can't see the question.
It's asking, what do you feel is the best way to do web prenatal visits?
Yeah, that is the question right now. For right now, the very best way, in my opinion, and this is always changing, is for them to have a home blood pressure cuff and a Doppler that they could replicate on the phone with you, a prenatal visit. In the absence of that, there's, fetal kick count log. We are doing some over the phone with HIPAA compliant telehealth. And it's just a learning process. That's the best way to do it, with a Doppler and a blood pressure cuff. And then there's lots of things in between based on what the client needs. Do they just need a phone check-in? Are they due for labs? I think that some combination of telehealth and in-person visits would be appropriate, with more attention to in-person visits as they get further along in their pregnancy. Rose?
And also I want to remind you to be sure and involve your students in if you have a way to have them in on the line or in on a Zoom call or something like that. In Washington, I heard yesterday on one of the webinars that midwives are doing a visit on the Zoom or whatever, like that's they're talking face to face, and they're doing their whole long kind of everything they would talk about. And then they're actually, now remember that Washington has got, they're in a bad place right now. but they're actually having people drive to the birth center, and they go out in the parking lot and actually take their blood pressure and their fetal heart checks. So, but that's clinics that they're trying to protect the pregnant person as much as they're trying to protect themselves. So it all depends on your setup. And we do want to also really be sensitive to the fact that we have low-income clients that are not going to be able to afford to buy, for sure, they're not going to buy a Doppler. Some people, again, we have to think outside of the box and think creatively. A whole lot of women with a little extra income have bought Dopplers for pregnancies that they no longer need. So some people are going on Facebook and asking people to donate those. If you already had your baby, donate them and then get those out to the low-income women. Same with home blood pressure cuffs if you have one that you don't need. So there's a lot of creativity going on right now.
So we have a really great question from someone asking if a client has all of the tools, blood pressure cuff, etc., and a virtual visit is happening with a student that's primary under supervision, can the student count that as a primary under supervision, prenatal or postpartum, if they are leading it? And
so I want to say that I advocated very heavily with NARM. I actually early last week contacted them and asked them to make a waiver that some visits could count for our students. Unbeknownst to me, two other leaders of two other MEEC schools had also made the same request of them. So it did get discussed, and it is in discussion. And right now they're having a wait and see attitude. But we are advocating for that, especially our students that are very, very close to graduating and they need continuity of care, and they're going to lose their continuity if they can't count a prenatal or a postpartum. What we're trying to do is preserve our workforce of midwives, because right now this is our time. Like, this is when the world needs us. In particular, there's never been a time like this, so we don't want to hamstring our own students. And losing a continuity could set students back, 6 months or a year. So we're not really worrying so much about prenatals for just most students, but the ones that are in continuities, we're definitely advocating. So if you have any feelings on that, if you feel like that would be just and fair for this time, then let NARM hear from you. Write them an email and make your voice heard. Thanks for asking that question.
Vicki, there's also a question about the evidence-based birth webinar yesterday, sharing recommendations to not encourage water birth. I know you were at that webinar, so do you want to comment on that?
Yes, so they did say that there are hospitals and birth centers shutting down water birth for now, and part of the reason is really that it's so very hard for midwives doing a water birth to not have some exposure. It's just hard. It wasn't necessarily that the birth was in any way dangerous for the mother or baby. It was more just cutting down risk of infection for the birth team. So that was a recommendation, and people are looking at that. But I think you have to, take that on a case-by-case individual basis.
Okay, I have not seen any other questions come through.
So if there's anything else, go ahead and ask us. Otherwise, we'll wrap this up and we will refer you to our new webpage, and we will keep updating that, and we'll get this. Oh yes, I'm going to answer the question on face masks, because this has been one of my it's been an area that has frustrated me hugely, because so many people are wearing them just in the grocery store and just to go out. But actually, as of last night, the best practice guideline is still that the person that should be wearing a face mask is either the person who is sick, the person who has a cough or sneezes, or the medical personnel that are working in the hospital that have a high risk of being infected while they're doing procedures like intubation and things like that. And in those cases, they should just be using an N95. So the actual little, you know, face mask, paper or cotton face masks are very ineffective. The things I have heard that I've heard both ways. I've heard, well, maybe if you wear one, it'll keep you from touching your own face so much. But then other people are saying just the opposite, that you'll constantly be adjusting it or pulling it down to take a drink of something, putting it back, and you actually might be infecting yourself worse. I think right now it's a frustration to us in our birth centers in the Philippines that people are being told they're not even allowed to step outside their house without having one on. And yet medical people don't have enough. And when I found out from my son that the clinic he works in California doesn't even have enough, and then you see everybody wearing them in grocery stores, it's frustrating. So have some and be ready to use them if you need to, if it becomes like something that people are saying we should be doing. But for the most part, what Manga said is more sense. Take your temperature, evaluate yourself. If you're sick, in the old days, 2 weeks ago, we would have said, if the midwife is sick, wear a mask. Now we're not saying that. We're saying if you're sick, stay home, don't go at all. So basically, yeah, the mask should only be used by medical professionals or people that have a cough and cold and that are out, you know, buying groceries or something. But I do realize too the power of perception. And so if you feel like you would feel safer or your clients would feel safer for you to wear a mask, right now there's a whole movement to make cloth masks. And a lot of people are spending their time at home doing that and trying to, you know, donate those. The latest study that I read on that said that they are about 50% less effective than the paper masks. So, but there are ways to make them, and you can go online and look for ways you can make them and put in different kind of filters or different kind of things that would make them a little more effective. There's all kinds of sewing patterns and people talking about it. So I don't know if that answered the question, but it's a frustrating question because evidence-based is, for our purposes, since we're not taking care of actual people with COVID-19 infection, it's not something that we need, but we do need to help there be enough for the people working in the hospitals and the people that are working in ICUs for sure. So. Okay, well, we can wrap it up. I appreciate everyone that's come, and I know there's so many more that are going to listen to this on recording. And again, I just want to say we're here for you, anything that we can do. I also want to acknowledge two things that are really important to acknowledge. One is that everybody feels fear right now of the unknown, but I also want to acknowledge that a lot of people have died, and a lot of people are sick right now and are dying as we speak, and we never want to forget that. It's been a really grounding thing for me since this whole thing started, that every time I hear another number, every time I hear another country outbreak, or every time, you know, the death rate goes up, instead of letting fear enter my heart, I've just stopped and prayed for those families that just lost somebody they loved. And I'm continuing to do that. I have to discipline myself to remember, like when we hear these big numbers, it gets overwhelming. But whether I hear of one individual person or whether I hear of just a really large number in Italy or Hong Kong or Washington or New York, I try to stop and pray for the families that are suffering and grieving. And one of our own staff in our birth center in the Philippines, one of our social workers just lost her grandpa and her uncle on the same day, and she wasn't allowed to go to the funeral. And I just really grieved for her, because part of the pain right now that our world is facing, and I say our world, it's not our nation, it's our world, is that people are losing loved ones and not being even allowed to do those cultural things they would normally do to grieve. So let's remember them in our prayers. Let's not take this lightly. Let's and let's really realize the gravity of the fact that this is a unique time in history where midwives have something to offer, that know how to take care of birth outside of a hospital. So God bless you all, and let us know how we can serve you.